ICS Edan kursun ikinci bölümüne başlıyoruz. İkinci bölüm anterior prolapsla alakalı. Mükemmel konuşmalar var. İlk konuşma her anterior prolaps tedavi edilmeli mi? Doktor Francisco Cruz sunacak. Doktor Francisco Cruz'un takdim edilmeye pek ihtiyacı yok. Kendisini hepimiz tanıyoruz. Hem işeme disfonksiyonu hem de kadın ürolojisinin Avrupa'daki en duayen hocalarından bir tanesidir Francisco Cruz. Kendisini zevkle dinleyeceğiz. Doktor Francisco Cruz.
Thank you very much for the kind invitation, particularly to Dr. Mesut, to Dr. Kunaz, who invited me several times, and I have here so many friends. It is really a pleasure to be here again. Thank you very much. Should every anterior prolapse be treated? Probably the answer would be very simple. The answer is no. The majority of the anterior pelvic organ prolapses should not be treated. And in the rest of the time, I will try to justify why they should not be treated. Okay, these are my disclosures. And let's start by the incidence. Probably the incidence of anterior pelvic organ prolapses will be around 10% according to these cohorts. But just look at the regression rate. It is significant. 17% of the prolapses in 5 years have a regression. So this is already an example that not all should be treated. In another study, in 3 years, measuring the progression more than 2 centimeters, of course, it occurred in 11% of women above 65 years of age, but a regression still occurred in a small proportion, but a proportion that is relevant, in 3%. The other argument, the prevalence is different if we consider it by symptoms or by examination. If we look to the prevalence by symptoms, we see numbers between 5 to 6%. But if we see the prevalence by examination, we see numbers between 30 to 40%. And the anterior prolapses are the most common. The posterior prolapse is the second one, and the uterine prolapse is the more rare type of prolapse. What this means? This means that the majority of the prolapses that we can see are asymptomatic, and therefore they might not require any treatment. By the way, the majority of the prolapses occur in elderly women when seen by examination above the age of 60, although 30% of younger women are presenting with prolapses. And of course, taking in consideration the risk of progression, they should be observed on a regular basis. Which are the symptoms that might be associated with the prolapse? Of course, related with the changes in position of the pelvic organs. And so we might expect pelvic pressure or pain. We might predict that many women will have the sensation of a lump or bulge in the vagina. They might have pain, back pain, due to the stretch of the mesentery. If the eversion is permanent, they will have excoriations and bleeding from the vaginal wall, and some will tell us that they need to reduce digitally the pelvic organ prolapse to urinate or to defecate. But then there are other symptoms, and we need to investigate them carefully because they will be important in the decision for treating or not treating. The lower urinary tract symptoms, stress urinary incontinence, bladder outlet obstruction, and even in some series, there is the report of OAB increase associated with prolapse. Then we need to check carefully sexual dysfunctions associated with prolapse. Many women with prolapse still have sexual activity, and we want to improve sexual function in these women. We don't want them to have dyspareunia. And many prolapse may be associated with defecatory problems, including the sensation of incomplete rectal emptying or constipation. So we need to investigate all these symptoms in addition to the symptoms that are related to the misposition of the pelvic organs. And it is interesting to see that the distribution of the prolapses according to the age when analyzed by symptoms is slightly different from that analyzed by examination. Many women are younger, and this may reflect problems associated with stress urinary incontinence, blood outlet obstruction, or sexual dysfunction. Well, in terms of treatment, there is, or in terms of management of pelvic organ prolapses, there is a good opportunity to prevent pelvic organ prolapses and eventually to reinforce the possibility of regression. Because, of course, we cannot change anything related to age, family history, pelvic trauma or surgery, or defects in the collagen formation. But certainly, we can insist with our women to decrease their weight if they are obese or overweight. Stop smoking. Treat the causes for chronic cough. Decrease the number, the amount of steroids they are taking if they need steroids. After deliveries, it is extremely important to correct severe tears and reinforce the pelvic floor by doing early pelvic floor muscle training. One point is not to remove the uterus just because the uterus is there. As we are going to see in a few slides, the uterus might protect women from prolapses. Well, if they have a prolapse, they should avoid heavy, at least as possible, heavy work and heavy lifting, and of course the treatment of constipation. One point that is very curious is the effect of mid-urethral slings in pelvic organ prolapses. And this is from the Thomas trial in the United States. Interestingly, the women that had a stage 2 prolapse, a symptomatic stage 2 prolapse, did not progress after a mid-urethral sling. And the progression rate was extremely low, and the number of women that received surgery was also extremely low. So eventually, if the woman has a pelvic organ prolapse and stress urinary incontinence, an early treatment for the stress urinary incontinence might be a good idea. On the opposite, to remove the uterus is not a good idea. As you can see, if there is no good reason for removing the uterus, there is an increased risk of increasing the grade 2 or 3 pelvic organ prolapses. We are in an ICS session, and so one point that is very important is to maintain or to use the same classification in order to know in the future what we are doing and if we are doing something correct. Of course, this is not easy, requires training, but that is the only way we have for the future to know what exactly we are doing. And that can be translated into a more easy stage that actually was already suggested by Baden Walker in 1972. So stage 0, no prolapse. Stage 1, prolapse that goes half of the total vaginal length. The stage 2 is the most difficult one because it is close to the hymen. It might be 1 centimeter above or 1 centimeter below. And then clearly the stage 3 and 4 are those that have an eversion almost permanently, and those are the most easily to indicate the treatment. But notice that this study on the prevalence by the POPQ system shows that the majority of the prolapses are stage 1 and stage 2, not stage 3 or stage 4. The management around the world is extremely variable. If you live in Denmark or in Australia, the probability of receiving surgery is much higher than in the United States. Living in Switzerland, the probability of receiving surgery is much lower than in the United States or in the other European countries. Probably skiing protects women from pelvic organ prolapses, I can imagine, or chocolate, I don't know. The transvaginal mesh that is banned from many countries in Europe, it is still used in European countries like in Germany, but not in England. Sacral colpopexy, which is an excellent surgery, is much more common in France, generally speaking, than in many other countries in Europe. And I think we are getting better because, according to the most recent data, the reoperation rate is decreasing. Which are the objectives? Restoration of anatomy is not the only objective. We want to eliminate symptoms, particularly urinary symptoms like stress urinary incontinence or bladder outlet obstruction. We want to restore sexual function in order to improve quality of life of our women. And what this means for anterior pelvic organ prolapses, that most stage 1 and 2 pelvic organ prolapses are asymptomatic and probably will not need treatment. The most high-grade cystocysts or anterior pelvic organ prolapses are the ones that are mostly associated with urological and sexual symptoms. Of course, we need to remember that a high stage or high-grade anterior prolapse might mask urethral hypermobility and cause occult stress urinary incontinence. So in the end, what do we have at this moment? And this is adapted from the ICI book 2023, the latest thing we have. We are back to anterior colpography. The results are not as good as in the previous reports from the last century, from 1980. We have, of course, more reoperation rates, particularly when compared to meshes, but we have less complications, and so anterior colpography is now very much used in the countries where the meshes were banned, and those are the majority of the countries in Europe. Of course, with the transvaginal mesh, the anatomy can be maintained and the outcome in the long term might be much better in terms of anatomy, but complications might also be much superior. For example, late exposures of the meshes might occur, dyspareunia might be present, and spontaneous pain in the vagina might occur. Anyway, still after the warnings from Food and Drug Administration, lightweight meshes are available and they are still being used. I think these women must be informed of the possible complications of all these meshes. Biological grafts, just going very quickly through them, to combine them with anterior colpography is not a good idea because they will not improve the outcome of pelvic organ prolapses or reduce the recurrence. Sacral colpopexy is a surgery I like, and particularly for those that are able to do it by laparoscopy or by robotic surgery, is an excellent surgery with very low numbers of recurrences. And so it is one interesting surgery that we should keep in our armamentarium. Of course, Stress urinary incontinence might be a problem because of the compression of the urethra or the distortion of the bladder neck. And so that means that during the examination of our women, we have to check if they have occult stress urinary incontinence. Carefully, whatever the method we use to check occult stress urinary incontinence, we cannot compress the urethra. Otherwise, we are going to have a negative test, and we don't want that. And so the latest recommendations are very simple. If starting on your right side, if there is symptomatic stress urinary incontinence, then recommend a concomitant procedure for the treatment of stress urinary incontinence. If there is no stress urinary incontinence, and if you go for colposacropexy, eventually discuss with your patient a birch colpo suspension at the same time. If you go for a vaginal procedure, discuss with your patient that to treat a stress urinary incontinence that is not present might not be a good idea, might increase the number of complications, although the risk of developing de novo stress urinary incontinence is real. If there is occult stress urinary incontinence, then stress urinary incontinence might be treated, increasing, of course, the adverse events of combining the two surgeries, particularly if the prolapse is of a big stage. Sexual activity is important to consider, and again, sacrocolpopexy reduces the percentage of women that has dyspareunia. And so it might be a good option for women with dyspareunia and prolapse. Don't use transvaginal meshes if you want to improve sexual function in women, because the risk of deterioration is real and really increases. And so, as take-home messages, I think the first important thing is to stage carefully pelvic organ prolapses, the anterior pelvic organ prolapse, to investigate symptoms that are associated, urinary symptoms, sexual symptoms, defecatory symptoms, to take in mind that most low-stage prolapses are asymptomatic and do not require immediate surgery. We should check other symptoms that are associated, particularly urinary symptoms, bladder outlet obstruction or stress urinary incontinence. If we go for surgery, inform our patients that de novo stress urinary incontinence might occur after the treatment, and the patients should be informed that sexual function is likely to improve if meshes are not used. Thank you very much for your attention.
Thank you very much, Dr. Cruz. We are going to take the questions after all talks.
Certainly.
Thanks a lot.
Thank you.